Hi, Mike Gibson coming to you virtually from TCT 2020, and I'm joined by my colleague, Georgios Vlachojannis. Welcome, Giorgio.
Hello, Mike.
Well, I'm very excited about what you're going to talk about. With Prasugrel, back when we first conducted the Triton trial, we found that Prasugrel was superior to clopidogrel, largely because what I call the 3 Ps. It's more potent, it's more prompt, and more predictable in its PK than clopidogrel. You did a study where you crushed Prasugrel and to make it even more prompt than swallowing it. And that was the crush trial. Talk to us a little bit about it. I mean, getting the drug on board as quickly as possible and achieving high levels of a drug in the setting of STEMI is absolutely critical. So seems like a great idea. What did you find?
So thank you, Mike. Indeed. So the reason for the study was, as you said, to have to see the maximum effect of all antiplatelet therapy with Prasugrel. As we know, this is delayed in STEMI patients, and by crushing the tablets, it has been shown to get the best pharmacodynamic profile out of these tablets. On the other side, here in the Netherlands, we use a pre-treatment scheme in the ambulance. So we gave also this medication at the earliest possible time point.
Just to kind of underscore that, Georgios, in STEMI, you have a lot of people getting narcotic analgesia, and that delays transit into the stomach, and you also have some edema possibly in the liver. Prasugrel does require some metabolism, just like clopidogrel. So a lot of things working against it to get it acting quickly.
Absolutely. I think with all P2x12 inhibitors and even with the potent ones, it is an uphill battle, right, in the acute phase of STEMI. So we were optimistic because of this impressive pharmacokinetic and pharmacodynamic data to achieve even maybe better reperfusion, early reperfusion in STEMI patients. These were our primary endpoints: TIMI-3 flow at first angiography, NST segment resolution at 1 hour after PCI. We had secondary endpoints. We looked obviously at platelet reactivity, at clinical outcomes, and we had the safety endpoint, bleeding at 48 hours, TIMI major or BARC 3 to 5. So we did not see any difference regarding the primary endpoint. However, we saw that crushed tablets work. They work good, but not good enough, it seems. We had at the beginning of PCI, significant reduction in platelet reactivity by 1/3. 62 patients who were treated with the integral tablets had high platelet reactivity. This was defined as PRU over 208, and this was reduced by crushing to 43%. So by 1/3. However, this did not have influence to the primary endpoint.
So let me ask you, Georgios, did you have enough patients look at other outcomes like stent thrombosis? Gilles Montelasco in his study, a similar study, but with ticagrelor pre-treatment, saw something similar, but did see a reduction in stent thrombosis. Any hints of that in this study?
We didn't see any signal towards reduced stent thrombosis, but we have to clearly say that our study was not powered for this. We had similar stent thrombosis rates, yes.
I have to say, looking backwards, gosh, that couple decades ago, frankly, when we combined or added in clopidogrel versus placebo, and in a large number of patients, 2,800 patients, looked at ST segment resolution early on, we didn't see any improvement. So, this is kind of really 3 strikes against the thienopyridines for an early effect. What we did see in clarity is a reduction in reocclusion. You saw, as Gilles study, a reduction in stent thrombosis. it seems as though these drugs are what you might expect. I mean, they block platelet activation and they tend to block reocclusion, rethrombosis. But it doesn't look like they're doing a whole lot, as best we can see, for disaggregating existing clot. And it's an interesting distinction versus the 2B3 inhibitors, which do disaggregate and break apart those existing clots.
Yeah, I am absolutely agree with what you said. It was a very high bar, this endpoint, absolutely. On the other side, if we go back to the Atlantic trial, which you just mentioned, we have obviously the Atlantic trial, the primary endpoints were pre-PCI, both ST resolution and TIMI3 flow. But if we look at in the Atlantic trial at ST resolution at 1 hour, we see a borderline p-value of 0.05. And once you exclude the patients who received morphine, you have a
Ah,
significance.
ah,
So this actually gave us a base to believe that at least the ST resolution endpoint, we had a good shot at it.
and that's 1 hour after the PCI. Yeah.
Exactly.
So again, after the procedure, starting to see some benefits. That's
Exactly.
fascinating. Yeah. Well, it's not, I'm so disappointed these days when I look at the ST segments and I look at the fellow and I say, why do you think the person's ST segments are still up? They say, oh, the stent is undersized. And I just shake my head. It's really microthrombosis and downstream embolization. And not all the clot is in the artery. A lot of it has moved down into the microvasculature. So, it's interesting. Perhaps we are inhibiting some of that microvascular thrombosis with this even more prompt and potent inhibition as you did here.
Absolutely, absolutely. I think this study adds to other studies that it seems that we can't get the job done. We can't bridge the gap with all antiplatelets in the acute phase of STEMI, and that we have to look for alternatives. And this next step seems to be parenteral. We're going to go back, I guess, to glycoprotein inhibitors. Now, a subcutaneous one is going to come in a phase 3 trial. Selatogrel. This is going to be also interesting to see how to apply this. So we're moving, I guess, back to parenteral, and we're going to see what this is going to bring.
Yeah, I'm a little more optimistic about the potential for the 2B3 inhibitors upstream, given subcutaneously. We saw good results for intravenous upstream use in a time-dependent disaggregation of clot. I'm not optimistic about selatogrel in the P2Y12s upstream. It just doesn't seem like upstream therapy with that class of drugs is really going to do much. Well, Georgios, congratulations on a great study, very well conducted, very important question. I'm very excited to hear the twist you talked about there at the end about morphine. It really does underscore the importance of considering a more aggressive parenteral approach when you're giving someone analgesics. By the way, in the label, in the FDA label for every one of these drugs, Prasugrel, Ticagrelor, or Clopidogrel, it says if you have administered a parenteral analgesic, you should consider a parenteral antiplatelet agent. And I think your study actually cements that kind of understanding. Thanks for joining us, Georgios.
Thank you, Mike.
And thanks to all of you for joining us here virtually from TCT 2020.